Okay. Okay, so patients with special healthcare needs include a broad spectrum. Like we said, it could be developmental, it could be sensory, behavioral, emotional impairment, physical limitations. There's all sorts of things. And then we want to be able to think about working interprofessionally with other healthcare providers or specialists as well. So dental hygienists need to apply critical thinking skills when seeking informed consent, because somebody, it may not be just cut and dry. You might not be able to gather informed consent from your patient. You may have to gather it from the caregiver. So sometimes we have to kind of navigate those types of situations. There's three dimensions of disability. There are impairments, activity limitations, and participant restrictions. Impairments can occur because of a pathologic condition, accident, or disease, and may include any loss or abnormality in function, which may or may not be permanent. So for example, somebody who has something going on, maybe they lost a limb, like permanently lost a limb, or they're going through some kind of, intensive renal, like dialysis, and then possibly on a transplant list or something. So that's an impairment. And an activity limitation is difficulty in performing activity of daily living because of a condition. So they might have difficulty performing oral hygiene, getting dressed, getting themselves places. They can't participate fully in kind of typical daily activities. A participation restriction is the inability to engage in everyday life activities for reasons that may not be under the patient's control. So something like working, having a severe health condition that keeps them from working or participating, accommodate. So those patients may actually end up needing special accommodations from employers, for example. Can you read that first? Yeah. So impairments can occur because of a pathologic condition. So it could be like a disease or something, maybe like something that happened during birth, or an accident, and may include any loss or abnormality in function. So a change in function that's just outside of what's kind of typical, or just a complete loss of function of something. And it may or may not be permanent. Mm-hmm. They do kind of seem similar too, don't they? I thought that the same thing. Mm-hmm. So a participation restriction, I would think of a little, since that word participation kind of being a part of something like a work environment, maybe even a school environment. So you might think about it in more of like a larger scope, and then an activity, something more like smaller, like personal things, like personal hygiene, that sort of thing. So maybe. I don't even think that's on the exam, frankly. The next one is, though, these dimensions of disability. I don't think I made a question about that, but I'll highlight.
I was going to say, could an example be like a patient who has autism, like maybe they aren't able to be in large areas because they have really big like sound sensitivity. Yeah. So like, maybe it's like the participant restriction would be like you can't be in large crowds at a concert versus like small groups are fine.
Yeah. So that's participating in something probably where like a bigger activity or bigger event or something like that most people are able to do, like work and school or concerts or social, whereas activity would be something smaller that just is stuff you might do, preparing food, it's like a little bit more on a smaller scale, or I want to say intimate, but I don't even know if that's the right word. Yes, yeah. So like being a part of a certain career as opposed to just doing that one activity. That's a good example too. Okay, common misconceptions are that individuals with disabilities are sick or that they depend on others, or that they are mentally and physically debilitated, or that they live in an institution, or that they're unable to live alone. So this can be true, but is it always true? No. Obviously, a woman who's pregnant is not sick. She's having a miracle happen in her body. She's not sick, but she has special circumstances that we have to be aware of. So obviously, we don't ever want to just assume somebody is sick or dependent or can't do something. It's like, that's one of the biggest things, like when you're dealing with a patient that you know has a restriction, and you can kind of tell right off the bat, there's some kind of a restriction. You don't want to just assume like the worst case scenario. You just ask questions, gauge, kind of figure out where they're at for their individual circumstance, because they could be far more capable than we give them credit for. So here's some terms with, this is probably easier because I got the definitions built into the slide. So normalization, process that enables challenged individuals to engage in normal patterns of everyday life. That's called normalization. Mainstreaming is incorporating individuals with special needs into conventional activities. So that would be more like school and work and that sort of thing. And then deinstitutionalization allows for special needs individuals to live and function independently with little or no assistance from a caregiver. So this was kind of a thing in the, I'm not even sure what the year when it started, but there was a big push to deinstitutionalize individuals, but it's been good, but it's also had some negative effects, because now there are people who have needs and their needs are not met because maybe family members can't take care of them, and so they have fallen through the cracks of society. But institutions kind of had a bad rap for a while too, because of neglect or abuse, and so there was this big push to get people out of institutions and to not be so dependent on that. And it's wonderful if they can, they can live on, on their own and have some assistance or have a caregiver, but it doesn't always work out as ideally as we would all hope. This is another important slide. These terms you're going to want to know for a quiz or an exam. Congenital disability and irregularity present at birth, which may or may not be traceable to genetic factors. So this is going to happen in utero. This congenital disability will happen while the baby's forming. Acquired disability, disabilities present after birth, can be traceable to disease or trauma. So they acquired it somehow through probably like an accident or something. Oh, wait, go back. Developmental disabilities, groups of conditions with impairment in physical learning, language, and behavioral. And this also is typically from like birth to 22, I think. So we'll have some more slides on these. Age-associated disabilities with people typically over the age of 65. So then we're talking about like arthritis or some of these age-related conditions. Alzheimer's, some age-related dementia. So developmental occurs congenitally or during development prior period of a child from birth to 22. It is typically chronic or continues throughout life. It doesn't, if it's chronic, it's always there. It's not just happening in one small section of their life. It's always going to be there. And it can be either mental, physical, or a combination of those. And an example of that would be like cerebral palsy or epilepsy. So that's developmental. And then acquired is a little easier to remember because you can just think of like a spinal cord injury, like a snowboarding accident or something like that, occurs after birth, generally traced back to either disease, trauma, or injury. Age-related or age-associated, so we're talking about some of the more common age-associated conditions: cancer, diabetes, cardiovascular, arthritis, osteoarthritis or osteoporosis, dementia, all of these. Those are all age-associated disabilities. So here's some barriers that we can talk about. Financial is always a barrier for, even if you don't have a special need, financial can be a barrier, but especially for individuals with special needs, they might have other medical expenses that we just aren't even like, aware of that that are prioritized over dental. So it can be really hard for them if they already have, an expensive medication or some kind of physical therapy or some kind of, other kind of therapist that they work with, and takes time and it takes money. And so sometimes dental stuff just simply starts getting lower on the priority list. Architectural would be things like physical barriers, getting to the office, maneuvering around the office. Transportation also is obviously getting to the office. If they live on their own or they live in a community, waiting for the specific ride to get there. They just don't have that freedom to jump in the car anytime they want. Attitudes of the provider and attitudes of the patient. This is really interesting because I think it might be on the next slide. Maybe no, maybe I did check it out. I'll have to look. There's some really interesting articles. Healthcare professionals can really feel hesitant because of, sometimes it has to do with money, sometimes it has to do with their time, their schedules. Your schedules are so like made out to the last second. And some patients that have certain special needs might end up taking more time. And it can be very difficult for offices to want to incorporate that. They're worried about, taking too much time. Time is money. And so sometimes they can be hesitant, or they don't take Medicare or Medicaid. So sometimes they can be hesitant without even really cognitively thinking about why they're being hesitant. So it's really important to evaluate, what are we doing to incorporate all of our patients so that all of our patients or anybody who's out there can access what they need. Fear, sometimes, if you haven't had many patients that have significant physical barriers or developmental or intellectual barriers, there can be a fear component, oh, what if they make a big scene and I don't know what to do? And so there can be a fear component. And so it's just learning about those different populations. More offices see patients that are on the autism spectrum now, because we have more in the general population. So there's a lot of wonderful classes on treating patients on the spectrum, but also patients that have different intellectual or developmental disabilities. They are seriously, sometimes they have been my absolute favorite patients, sweet and happy patients, happy to be there. It's like an outing, they're all excited. So sometimes it's a fear and you just have to, be exposed to it. But sometimes that is a barrier, an attitude barrier from health professionals. And then on the flip side, the patients can feel like they don't get me, they don't want to see me, it's too difficult. So they have the same fears about it, but it's on the feeling not feeling included or wanting, not wanting to be there, being misunderstood by the provider. So it's just that exposure. Everybody has to kind of be exposed to each other and realize that it's okay. So you have to welcome patients into your practice and have that experience. Okay, so some other terms that might seem a little bit I don't think these are you're not tested on these very much. I should probably just maybe skip them. Let's just keep moving. Okay, interacting with people with disabilities, asking questions, finding out, not assuming. How can I help you? What can you, show me what you do. What's your typical this or that? Or watching them maneuver through the office, moving stuff out of the way for them, offering your elbow to help lead them through the hall. So it's just being open and aware, and it's part of what you develop as a clinician. You just develop these skills innately, and if it doesn't come, if you're not somebody that it just kind of flows out of you normally, it will more and more the more patients you see. And just remember, that's part of what makes a wonderful clinician, is somebody that is putting their patient first and thinking about their needs. Person first language is really important. I don't always stick to this. Everybody slips up, nobody's perfect. but really you want to ensure that when you're talking about somebody, that you put the person in front of the condition. So instead of, if you have a diabetic patient, it's not, you know, Mrs. Jones, she's my diabetic, my diabetic patient. It's, I have a patient that has diabetes and she comes in it too, or whatever. So it's always the person is first and then their condition, or, like, oh, that's my, whatever, my stroke patient, or I don't know, whatever you can think of. Sometimes it just slips out. I've done it, and I've heard other faculty do it and they reverse it because it's an etiquette thing. It's kind of like, but sometimes we forget, but just try and remember person first, then the condition. I don't know what I think we lost Angela. Okay, so position some other things, not assuming that we talked about that they're sick. Positioning yourself at eye level if you're talking with somebody in a wheelchair. So making sure but it's just good etiquette anyways. You guys do it already. You sit your patient and then you sit down and you're eye level with them. So it's just, you don't want to be like looming over them and talking. The term handicap is no longer used. It implies that a person is at a disadvantage. So usually it's like a disability, or I'm sure there's another term that I'm just not thinking of. This is just incorporating, it's instead of thinking of like, it's like a whole new set of skills, you're just kind of incorporating things that you kind of already possess, really. I liked this quote. I won't read it, but you guys can. Assistive devices. So when we talk about assistive devices, we're talking about all kinds of different stuff. We're talking about walkers. You can see here, canes, it could be anything to help them ambulate through the office. If it's something that they are not going to use, you want to keep it close by and just assure them that this is where it is and bring it back to them once they need it. So, they sort of like something that they depend on. So you don't want to just, throw it out of the room and then not have them, have them wonder where it is. So you want to keep it close, retrieve it when they need it. If patient moves the device, inform the patient. Just, I'm just going to put it around the corner here. And, it's just all of that stuff, talking about stuff instead of just assuming that they're okay with it. It's just nice. With wheelchairs, you can ask them if they need help. We'll talk about wheelchair transfers. You don't want to transfer someone out of a wheelchair all by yourself. Even if you studied the one person wheelchair transfer, you really don't want to take that on all by yourself. There should be a second person there. And so the person who's in the wheelchair may actually be able to transfer themselves. So you just have to talk about it, find out what the deal is going to be, and then get somebody to help, because you don't want to throw your back out or have someone end up on the floor, you know what I mean? Because it can be very tricky. So may or may not need assistance from transferring. Ask them and ask for help for sure. Yeah. We had a hygienist. That is what I am talking about. I would never, even though we talk about how to do a wheelchair transfer, I would never do it. I would never do it. I had an older gentleman who was out in the waiting room, and so I went out there, and he wanted my arm to help so he could get up out of the chair. And so I kind of just gave him my arm, and he yanked my arm like almost out of socket because I wasn't ready for it. And he was a very big man, and I wasn't ready for it, for one, but even if I had been, I would have had to have been like, I mean, it was not, and my shoulder hurt the rest of the day. And he didn't mean to do it, but it was just one of those things, like, your body is your moneymaker, and you just want to be very careful. You want to help your patients, but make sure you do it with like a team effort. Get the doctor to do it. If someone needs to move someone, get the doctor to do it. I think the best thing to do is, if there is a caregiver, talk to them about it. And if you know already just physically you have a sensitive area, like you have kind of a sensitive back or a bad back, go to the doctor and say, I need help moving this patient. The caregiver's here, she can help, but can one of the assistants or can you do it? Like, you know, ask the doctor and just say, I just know that I can't move this. And you could have that be some, kind of something you have talked about ahead of time so that, you know, he or she knows that if that situation comes up, you're not comfortable moving patients. I never wanted to move just because I knew I physically couldn't do it. And everyone's different, you know, some people, you know, might feel better equipped for that, but I never did. So prosthetic devices, you want to be familiar. You can look up in our clinic manual about the policy. Generally speaking, patients don't have to take pre-med, but some orthopedists still want them to take pre-med. So you have to kind of check with the patient and just go back into the clinic. I won't pull it up because you guys can do that on your time, but make sure you review the policy in our manual as well. Usually it's, you know, knees or hips, but it can also be shoulders and different joints, but usually knees or hips. Okay, so let's take a break. Say it again. It's the same, like 2 grams of whatever amoxicillin or whatever antibiotic, and usually like an hour before, but they just don't. I mean, if it was up to the dental side, they're like, you don't need it unless you've had a significant infection in the joint before. But a lot of orthopedists or those doctors still want their patients to do it. Sometimes just 2 years after, sometimes lifetime. So let's do, it's my clock says 2:25, so let's do 2:30. When do we go till 3:20? Okay, oh my goodness. Yeah.
I know, it's nice. It's not like a longer weekend. Kick people out if they don't take professor. No, they.
Oh my gosh, I was like, I'm just gonna use my bell. It's gonna be like, ding, ding, ding.
Get out.
I'm just not a mean cat. Every once in a while, I might be like flabbergasted, but I just can't. I'm not a mean. But you know, that's Gail. Gail's probably gonna do that.
Get out.
Out of my room.
Or I would call them out.
Well, I know you guys you're all like, it's the first day back and everyone has stuff to chat about.
No, there's never that much stuff. Yeah. We're best friends.
You're like, after a while, there's no more to talk about. Yeah, it's one of those crowd management things, right? You gotta learn crowd management skills. Where is my mouse? I was gonna pause the recording so you guys don't have to sit and listen to this yammering, but I lost my mouse. Yeah.
When you were talking about the
Mhm.
you and I were talking about it, and we're watching everything over. So just like wondering what your experience is like with what this did, like by taking people out of institution and how that happened.
That's how I was gonna try today, but I forgot.
Like what drops.
I was like, oh, I gotta do that.
And it's so hard. It's like my husband says things. They need to process these people. And it's like, and what he means is like criminal state. not everyone in some people need, you know, like assistive medication and like people that care for them.
And they're health is like not really,
Yeah, and then it's jobs like the institutions here, you know, and yes, there was some institutions that were horrible.
and I should have been shut down because they were just
Yeah. So I personally think that that's been a huge problem. Is that they're like, and now it's, I feel like it has an impact.
Yeah, I think that was like the other thing we were talking about is about 10, 20, 30 years ago, like the talking mental health was not a conversation people were having. But like I think that our generation is doing a better job of like normalizing that and normalizing it. They normalize it because like depression and bipolar and like all of these things. And so I'm just curious of like if you feel like some of those misconceptions that are based around these topics that are not talked about, including like homeless population and things like that. And the fact that like just by looking at somebody who can't find out, like, do you think that I guess like is that and is something that could change like the more that we talk about it?
I think it needs to be recreated. Like you can't just dismantle a system without fixing the problem. I feel like they just shut it down and then what? So I feel like if they created more, you know, maybe more accountability within the institutions, and I don't know, I mean, that's not my area of expertise, but I feel like just everyone out probably.
It's so interesting to think about it. So my boyfriend works at a museum, and he just transferred to the largest school that does in the library, and so he was having to fix and on his higher mental health. And it's just so interesting to think about like these people who did something that they did, but now they have been diagnosed with mental health disorders, like they're probably getting better care because of routine and structure and things like that. So like, you know, sometimes that's a better option because the other option is
Or like be able to like go back and then if there's other social services like, you know, job placement or housing placement, but these people are just like, without addressing any of the other support.
Yeah. Hi. Sorry, I got up like a few times.
No,
I should have told you
you're
before. Tomorrow, the
Mhm.
Indian Center, Health Center, they were calling me a couple times to get the fingerprints set up, and I should have told you. I had to go.
No, you're fine. You're
Should be
good.
good now, though.
Okay, okay, no, you're fine.
Because I saw that Diana. Well, that's why I asked, I was like, yeah, I was like, yo, do I have to get them 30 minutes early? Because that would mean I have to be at 7. She's like, no. And she's like,
Okay.
we're gonna be doing sterile while everyone's setting up. So I was like, okay, well, when do I set up? Oh, what does that mean?
Okay, so I am probably, I'll just add aggression to my thinking.
Like this.
Be like, ah. So we do have, okay, so I set an alarm for 3:20 and so I'm going to, I realize there's no way at all that we're getting through all these slides. So I am going to go a little faster. This stuff here, the rest of this slide deck is very kind of self-guidable. This is not high tech, how the cardiovascular system works kind of thing. This is very self-guiding. So I'm going to just go through these, do read through these slides though, but there's these different, because some of it will talk about things that you need to know, like I'll just bring the attention to this. Ultrasonic devices and handpieces in close proximity of operator may cause hearing aid to squeal. So patient may want to turn off their hearing aid. So make sure you read through these slides so you pick up on things like that, because that could be on a test. That's a good test question. So make sure that you have read through these slides. Assistive devices for visual impairment, patient. Oh, I meant to pause it and then I could never, my mouse disappeared. And so I still am recording. So yeah, I meant to turn it off and then turn it back on. And you guys are going to hear a little side conversation, but that's just fast forward. So treating a patient with complete blindness, I highlighted the grasp the elbow. So pay attention to reading that. You want to know about how you guide a patient who's blind. Guide dogs are permitted. Assistive devices, there's these augmentative and alternative communication devices. Some of them are those boards that you can pictures or type in, different kinds of speaking assistive devices. And then there's assistive devices for somebody who's completely paralyzed, like quadriplegic. They're called a mouth stick, and we'll talk about that in a little bit more in another segment as well. We'll show pictures of them. But these are different kinds. It's something, it's kind of like a mouth guard with all different things that are attached to it. It could be like a paintbrush or a pencil or just a wooden stick or well, maybe not a utensil. Maybe, I don't know, just all different kinds of stuff to help them navigate different kinds of activities. So that's what a mouth stick is. These are some images here. This, at first, it can be kind of hard to figure out what you're looking at, but this, I want to get my mouse over there. This over here is called an obturator, and what it is, this big bulgy part of it covers up. This is somebody who's either had oral cancer, or maybe these can also be used for cleft palate, patients with cleft palates. So basically plugs up the palate so that they close that sinus communication area from up and around the sinuses. So it kind of plugs up that open space. So that's an obturator. And then over here, this individual probably has some kind of an ID or a DD, intellectual or developmental disability, and they're doing a self-biting. They're doing a traumatizing repetitive motion. They could be on the spectrum, like autistic spectrum as well. That can happen. So they've developed this huge, like, calloused thing on their lip just from continually like biting. And so they're wearing a mouth guard to prevent that from happening. So that's what that is. Yeah. I have no idea where my mouse is on this side of my, I want to go backwards. This over here.
No, she went all the way
over. Oh, this part? This is just more like plastic. So what they do is they take an impression, just like you guys took your impression, and it will have that extra bit, and then they're able to just like pop it in there, and it just seats up into that space. So oral self-care devices, few assistive devices help patients carry out oral self-care behavior. Patients with disabilities may benefit from specialized toothbrushes. So a couple things you want to think about are the patient's needs, their specific needs, their skill, and their functional status. So we're gonna, let me see what the next slide. You also want to think about things like their actual ability to manipulate it, their range of motion. Do they have any limitations in their range of motion? Their grip strength, can they grip, or is it very weak and they don't have a lot of grip strength? And then their skill level and cognitive application. So are they, somewhere like still in like a, like an elementary or up to just a certain age, like a young person cognitively, they're only going to be able to learn so much up to a certain complicated level, or dementia, have they lost those abilities so they're only going to be able to do things very rudimentary or like by habit or repetitive. So you have to figure out those things kind of where they're at. So just a little bit more in those areas, thinking about their range of motion, their grip strength. If they have a very weak grip, then you can do things like bulk up the handle, you can add a strap. If they can't squeeze the toothpaste, they make some of these really neat little devices that is a toothpaste squeezer. You can, if their dexterity, they can't move around, you can get these neat toothbrushes that brush on more than one side. So there's so many things, and we'll look into those more when we're looking at the different populations, but there's just, and you guys can just do searches, you know, like if you have a bored moment, just do searches of, oh, there's so many, there's suction toothbrushes, and there's brushes that are like for the whole arch or for half the arch. I mean, they've just come up with so many different tools that you can use. So current oral status, you want to look at their current oral status, see what their current technique is, and kind of see what you can do to augment it or help them to improve on it. And then you think about stuff too, like if they have a tongue thrust or tightness in their cheeks, what's preventing them from actually even getting in to a certain area of their mouth to access the teeth to clean them. Customizing oral healthcare devices. It's also an opportunity to meet somebody from another profession, namely occupational therapists. They tend to have a lot of knowledge in this area because that's what they do, is look at fine motor things in life and figure out how to help the patient navigate. So an occupational therapist is a wonderful partner for things like this. Wide variety of equipment that's readily available. Patients with poor dexterity and coordination and or limiting gripping ability may benefit from a power toothbrush or a larger handle. So some of this is just repetitive. But physical therapists as well, but occupational therapists is probably one of the best to collaborate on a topic like this. So customizing, you can do things like, I mean, literally whatever you can think of is gonna, you know, you can be creative in this, but you can use bicycle handles, you can use, people have used molding putty that like hardens, you can use like a towel and a rubber band, like just take a washcloth and put a rubber, I mean, just whatever to bulk it up and make it easier to grip. Power toothbrush, oral irrigators. Oh my gosh, now my throat is getting dry. Basically, you want to make sure, look at the bottom line here, you want to make sure it's lightweight, it's easy to use, it's cleansable. So if it gets real gunky real fast, you know, that's probably not the best thing. Interchangeable, minimal setup time. You know, you can add other things to it like inexpensive, easy to understand and use, you know, so you just want it to be practical. So we'll talk a little bit about stabilization. Stabilization is when you have to use something like maybe you have to restrain the patient a little bit, or you have to support the patient in a specific way. You can also think about it in terms of like propping their mouth open if they don't open or they keep closing their mouth. So there's different, but it's something that you're going to have to use some kind of a device or a physical intervention to get the patient to either hold still, support their body, stay open, some of these things. Active stabilization involves physical immobilization by another person, such as a parent, caregiver, and assistant. So if you are gently holding your patient's hands on their lap, you're actively stabilizing them. Passive stabilization is using something like straps or what they call like a papoose. What's that? Yeah, papoose board where you've like locked them in. It's like a straitjacket, like you've locked them in, and so they can't move. So that's passive. That sounds more active to me for some reason, but I think they define it as active because somebody else is like actively. It's kind of weird. Yeah.
I was like, no, I can't.
Yeah.
I mean, they were like so high on drugs that, like Dr. said, that they didn't care. When I did it, so they didn't care.
I think that's the thing is it's like if they're going to be heavily medicated, or if they are a danger to themselves, or you know, there's very, very specific and good reasons why you would do that. Requires a little bit more education. So if any of these things, the mouth prop, you guys are all used to using bite blocks, but if you're using it on somebody with a very specific intellectual or developmental disability, you have to just be a little bit more people, if you have a patient in your chair and you say, open up, no bite, and they just lay there with the bite block in their mouth, that's easy peasy. But if you're dealing with someone that's going to keep playing with it and keep spitting it out, that's not so easy. So you have to kind of know, you might have to use something else like it looks like a bite block, but it's like a stick, and I'll show you here in the next. So you might need a little more education on it, requires informed consent. Dental hygienist must explain indications, benefits, associated risks of protective stabilization, as well as alternative approaches. So you definitely want to talk it through with caregivers.
I just have a question on this taboo score. Because doesn't that have the potential of increasing dental trauma /
Totally.
100%.
So 100%.
Shouldn't, why
When it requires consent, you can't do that.
well, and I understand that, but like, why would that still be something that we use? Like, shouldn't there should be other methods?
Free. So what we had to do is it was an adult patient that was severely autistic and wouldn't let us see their mouth at all with a mom with them. We're not. That was the only thing we could do without putting them under. Yeah, like sometimes if they just literally need like one single crown or like a piece of sealant, if you're gonna, not all offices do it, but like I worked at an office, we would give them first ed, they would get nitrous, and then we would monitor them, and it's a lot easier than the parents pay $800 an hour
To go to the
to
hospital.
go to the hospital or to it under
Very, very patient specific.
I woke up in a papoose before because apparently when I go under anesthesia, when I come out of it, I try to rip out my IVs. And so they said that I was like scratching myself and like hurting myself. So they had to like restrain me and re-sedate me and restrain me, which was better for me because I was trying to rip out IVs.
And I've been in that situation where they have like blood is everywhere. Because
Yeah.
They ripped out their IV, I'm getting kicked in the face, and it's taken like 5 of us to hold one kid down.
Yeah.
So,
It can get,
yeah, the
that's
super strength you have under anesthesia
For real.
is
Yeah.
insane. Yeah.
like super person.
No.
I've seen like 3 grown men on top of a 4-year-old, like calm her down, and it was a girl, and she was like all over.
That's like last night, my husband and I were trying to get jammies on Lola, and she was like, it was like a cat in a bag. It was like, "Meow!" And that was just one little 2.5, almost 3. But I think it's a bit, you bring up a very valid point though, Bree, is that this is not willy-nilly. This is very specific. Everyone's got to have a certain amount of like education and understanding. Everyone's going to be in full agreement, and you want to minimize that trauma. So it usually medications are involved. It's not just throw them in a papoose. It's usually medicate them to make sure that they're not traumatized by it. So why would you use it? So neuromuscular impairments, they may require, so if somebody has like cerebral palsy, or there's something where they move without any kind of ability to stop the movement, you cannot do dentistry on a moving target. You just can't without injury. So it's for the patient's safety as well. Aggressive behavior, mouth props can help from trauma from biting. Use protective stabilization devices with caution for patients who are prone to seizures. So, I mean, it is not a willy-nilly. It's a very thought out, this is the best course of action for this situation. So we have some examples. This is, I mean, it doesn't look any more straitjacket than that. Here's just a very relaxed, mom's holding the arms and the kiddos in the dentist's lap. So that's just a very usually happy restraint. Here's some mouth props. You guys can see there's that suction thing like what we have, or sometimes these are used for sealants, or this is the bite block, or like a bite stick, or just a traditional bite block. So sometimes, and then there's beanbag chairs. So stabilization can also be pillows and things like that to help support the body. It's not always restraints. Seriously?
Literally.
If this is your experience your whole childhood, you probably, unless it has been done in such a way that has made the child feel safe, even though they have been restraint, but I don't know, you probably hate the dentist, I'm assuming, if that's your experience. Here's a different kind of restraint. They just have their arms in these sleeves. Doesn't she look happy?
I was just saying, I want this for when I sleep. It looks
Yeah.
weighted.
Yeah, this is the best thing. The weight, they felt comfortable. I've had patients say, can you just leave that on me? They just like the weight of it. I even have the blue. So here is some, I think that these are stabilization technique. Here's an article, guidelines for protective stabilization from pediatric dental patients. This advanced behavior guidance, I think this is an article, and here's a video. I'm not going to click on them because we just don't have time, but click on them and just skim them. Or I don't remember how long this video is, but just look at those. I don't think anything's from that's going to be on an exam, but just for your information. Patient positioning, a lot of times with elderly patients, you can't lay them back all the way. They have difficulty laying back, especially if there's some kind of a coughing, choking, aspiration type thing where they have difficulty swallowing or they just get dizzy. So you're going to have to get comfortable with sometimes keeping patients more upright, using rubber dams, or the suction thing that we have. Isolite. Caring for patients. It is, yeah, it is. It is a mouthful. It's true. And if they have any gagging, or they might not like that either. Patients with wheelchairs. These are pretty neat devices. If you worked in isn't that cool? If you worked in an office that had one of these that accommodated, these you probably see more like in an assisted living where they'd have a room where they have one of these so that you can easily do dentistry at the assisted living or the nursing home. But some dental offices do have these, few and far between, but they just roll onto it and it locks them in somehow and then they go back. I just think that's great. So considerations and complications in wheelchair, do pay attention to the muscle peroxism. Why am I having trouble? Paroxysm, muscle spasms. So be aware of some things that can happen with patients that are in wheelchairs. They can have pressure, like sore areas from pressure sores. What's it called? Pressure injury. It's like they used to call them just bed sores. It's like if you just constantly laying or sitting in one area. They can have a catheter, so you have to, or some kind of a bag, for going to the bathroom. So you have to be very aware if that's happening. You don't want to displace that at all or pinch it or anything like that. And then the muscular, the spasms undergoing wheelchair transfers are at an increased risk for experiencing muscle paroxysm. Am I saying that right? My brain is fading fast, but paroxysm, but muscle spasm. So those are some things that you guys need to know. The other thing I want you just go through these, this information, but do pay attention to this part here. Let me see. This talks about preparing the operatory, preparing for a transfer. Dental chair should be slightly lower, or even is fine, but slightly lower than the wheelchair. So just think about this. If you were to transfer your patient, you don't want to like lift them up into the chair. You just kind of want to like move them to the chair. So that's a good test question. So just be aware of your dental chair should be lower than the wheelchair, just for ease. Think of ease of transfer. And just kind of pay attention to some of those. Here we go again with the muscle paroxysm, pressure injuries. These are things to be aware of with patients who are in wheelchairs. So read through these. These are some good things. These videos are good. I think the person in this video, it shows a lady who, and I was watching, she's got a bunch of videos on YouTube. I watched her transfer herself into a dental chair. And then I got like caught up watching all these, and this was like last year. So it's been a while. I can't remember what her circumstances are, but she was paralyzed after, during like midlife. And then she's just does all these videos on how she like navigates the world now, and very, very interesting lady. But watch this one because it shows how she gets into the chair. So this, and then this one would be a transfer video. Oh, I wrote this lady is amazing. That's so funny. So maybe this is the one with her and this is the transfer. And I don't remember what this is. This looks like an article. So summary, this just reviews the things to think of when it comes to wheelchair transfers. Health promotion and advocacy, as with all of this stuff, if somebody doesn't become a champion for this, it just is very easy for it to fall through the cracks. So not everybody, it's not going to be everybody's cup of tea, but advocacy and like promoting fairness in your, talking to your doctor, hey, have we ever thought of like, going out and recruiting patients at, this place or that place, or seeing, I always tell, whenever I talk to groups about geriatric stuff, I always say, when you follow your patients for a number of years and then all of a sudden they disappear and they're floating off into assisted living and nursing home, don't just forget about them, follow them and ask your doctor if you can start a new line. You have your EPDH, say once a month or once every 2 months, can I have a day where I just do EPDH work? Can that be a new part of our business where I go and I we invest in some mobile equipment? It doesn't even have to be fancy. It can be super, super basic. And I travel and it gets you out of the office 1 day a month, who knows, it could get bigger and you could do it, 2 days a month or who knows, but somebody has to care about it and advocate and promote and that sort of stuff. So you can participate on councils, local boards, organizations, initiate community programs. So think about like your capstone, thinking, you can, whoever, when you guys start your capstone this semester, you can start to experiment with that by thinking of things now in school to create a community program, like the mouth guard clinic, for example. That was a capstone project, and now we do that every year. So just to provide a service. Okay, any questions on that one?
In general,
Yeah.
when we figure out who our partners are, do you want us to like email you for the presentation, or are we just gonna let you know next week?
Yeah, let's do, what does it say? I can't minimize. Okay. Let's do, figure out your partners. And I know. I'll make a Google Doc that's the partner sign up.
Mm-hmm.
So I'll post that today. I'll put a Google Doc and I'll send you guys the link. And then next week, I'll have you guys pick the for drawing for who picks which topic. Yeah. Oh, the rubric for the presentation? Yes, I haven't actually created it yet, but I will probably do that this week since it's coming so fast. So I'll probably do it either tomorrow or Thursday. Probably tomorrow though, because tomorrow is my most open day. So I'll probably get the rubric up by midweek, I would say. It's that Google, I'll send out that Google sheet again so you can look over them. I don't know that it's
Or we're randomly picking them.
yeah. So what you'll do is like, here's the sheet, and once you have your partners, once you know what order you can pick, we'll do this in class so that it's fair that way. So you'll all pick a number, or the one of the partner groups pick a number. And then if you got number 1, then you get to come into the Google Doc and put your name in first. So you guys can look. Yeah, so you'll pick one. So look this over. You guys should have access and be able to get into it. If not, I'll make it. You don't? But don't put your name in yet until because we'll pick in order just to make it fair. We'll just pick in order of what number you draw. So it's just going to be like random. But you can look at the topics and get an idea of, okay, if these are the 3 that I'd like. So hopefully I'll be able to get one of those before. So now I made it anyone with the link. So now you can go in. So here on the course, it's here. I hid it. Let me unhide it. So don't write on that Google Doc. Just go in and familiarize yourself with the date, the times, and the topics. And then next week, once you have your partner, we'll pick numbers, and then you can put your name in. We'll solidify that next week. What's that? Oh, still not letting you go in? Huh. I'll email it out to you guys as well. You should be able to. I thought I did share it with anyone with the link.
You need access.
Huh. Why does it do that? Here, let me try again. That's perfect. There. I'll send you guys that. So yeah, so don't write in it, just look at the topics. Okay, we are dangerously low on time. Let me pull up this last. No writing on the Google form. I'm gonna delete it.
Go on your email then. I think those ones that it has. Yeah, well, you got
Okay.
So we blocked Janice from the Google Doc.
Yeah. Everybody except for Janice. Okay, so there's 29 slides, 28 not counting, probably 27. There's probably a question slide. So I don't think I'll get through it all, but this is mostly talking about, there's a section here for Down's syndrome and autism are the main ones. So, but you can also incorporate other IDs or DDs that we might not be thinking of at the moment. So poor oral health puts kids with special needs at risk. I just thought that picture was so darn cute. So I thought it was adorable. Let's see if I can advance the slide. Wait, oh my word, what's going on?
Absolutely not. Shanice's hair isn't that dark. No, it is not. Girl.
I know, there's no way this is gonna work out. Okay. These are the objectives. I am not reading them. Developmental disabilities, lifelong, severe, chronic disability that can be cognitive, physical, or both. Kind of I think that we had that in the other slide actually. Intellectual disability, ID. So sometimes we just shorten these to DDs and IDs. Intellectual disability, developmental disability that's characterized by significantly sub-average general intellectual functioning that can also, it's accompanied by significant limitations in adaptive functioning. So being able to adapt to situations in at least 2 skill areas. And I think it goes into that a little further in the next one. Oh, no, it's right below it. So skill areas are things like just, communication, behavioral, being able to function and do various tasks, work, leisure, health, safety. So something significant is being affected in at least 2 of those situations: self-direction, functional academic skills. So any of these areas here, these skill areas. Etiology, intellectual disabilities can stem from the following. It can be genetic, biological factor. It can be non-genetic, so it could be prenatal, perinatal, or postnatal crisis, something like an infection, or or even alcohol, or something, some kind of a disease or a virus or something that affects that then affects the baby, or it could be some kind of a chromosomal genetic thing. And then psychosocial factions, inadequate caregiving, babies that are ignored, they're never touched, they're never held. I don't know how much you guys have learned in other classes about, like, back when babies were in the NICU and they were preemies, they never touched them because they thought, oh, they're so fragile. But they did so much better once the nurses handled them and they got actual physical. And then of course, babies that are in orphanages that are never touched, they can have significant intellectual disabilities if they're not loved and touched. I'll have to write that down. That's just heartbreaking. Because it's in those, it's just in their, you can see so much, the more you talk to your kid, the more eye contact. I mean, that's why facial expressions to children, it's so important, for them to see, and I mean, all of that stuff, but physical too, physical contact. They're probably the world. Yes, I know. There's gotta be, hopefully we will barrel through this and there'll be light at the end of the tunnel, but yeah, it is serious for sure. Okay, so we're also talking about, it could be traumatic births too, back up to that non-genetic biologic, that could be traumatic births causing some kind of, brain injury or something. So there's lots of different, poor nutrition, drugs and alcohol. There's lots of things that can affect the development. So this is important for you guys to kind of read, and I tried to bold areas here that I want you to really kind of pay attention to. So mild ID, levels of intellectual disability, educatable, so you can, they are certainly able to learn. So I think about this in terms of when we're educating our patients about treatment plans and disease processes and OHI, but see how it says attention span and memories are short. So that's a key thing that I want you to pull out of a mild ID, so that when you think about explaining stuff to people, you kind of make it succinct and short and sweet, and unlike me, you don't ramble on and on and on and find a million different words for the same thing. So it's kind of have to get your spiel down to a science, if you know that there's some kind of mild intellectual disability. Moderate, I highlighted the poor hand and finger coordination. So that's something to really think about. There can be capable of learning self-care behaviors, social adjustments, and economics. There's usefulness, but they might have barriers like the poor hand and finger coordination. They might be living in a group home. They're obviously going to be more dependent on caregivers when they hit this moderate level. Severe, the learning happens by habit training. So explanations is not going to work. Repetitive habit formations is what you're going to need for severe ID. And profound, they're not going to be able to care for themselves, their own oral hygiene. You're going to have to be educating the caregiver, really, and they're going to be doing the OHI and understanding the process and all of that. Some different kinds of rewards. There's social rewards. That's that, happy disposition, welcoming someone, smiling to them, asking them how they're doing, showing that you're pleased with them. Those social rewards. Activity rewards, something that someone might enjoy, like, well, if you can make sure that you're doing this, you can, play your video game or whatever the thing is, or go to a party, or watch, go to the theater, or something tangible, or an activity that you can, like, bribe sounds terrible, but have them look forward to. And then there's material things like giving them stickers, or a xylitol lollipop at the end of the appointment or something. So there's different kinds of rewards, and different people will respond to different things. Some kids could care less about stickers. They just throw it on the ground, and others think it's like the best thing in the whole world. So
We have xylitol lollipops?
I just bought a whole bunch to bring in. They haven't come in yet, but I'm going to keep them in my office, so you guys can just grab them at will. But I think all offices should have xylitol lollipops. Who doesn't want xylitol lollipops? Yes. They're a little bit back ordered, but they come like in a thing. And they're, that movie, The Boss Baby, they like have Boss Baby on the box for some reason. I don't know why. Okay, so health, some of the things, again, I kind of highlighted. I should have put it in a different color because it's kind of hard to see, but delayed. So with the health, there can be less physical stamina, delayed physical development and speech. Some of these I highlighted that I feel are really kind of maybe more that relate specifically to in the clinic, like when you actually are seeing the patient. Short memories, mental and motor abilities, lack of adaptive or organizational skills, some things that might actually really impede their ability to get some good oral hygiene activities done. Short memories, social and emotional abilities. Criticism is not taken positively. I highlighted that because, sometimes you have to really dance around the way if their oral hygiene is just atrocious and it's a mess every time, and you can't just obviously say that. And this goes for anybody, because people can be sensitive, but especially if they're not going to respond well to anything negative, got to figure out a way to work that conversation so that they don't feel that it's a criticism. So that's along with the social and emotional abilities. Self-injurious behavior, that's that self-biting, may include head banging, self-biting, self-striking, or bruxism. So that those are things that may need some intervention from like a mouth guard or some kind of a protective device if they're causing a lot of damage. So general characteristics, some oral manifestations, some of this is repetitive, but self-biting, bruxism, thick or flaccid lips, microdontia, so small teeth, or malocclusion, a lot of crowding, or just maybe, like class 3 or class 2, some major malocclusion, delayed tooth eruption, dental attrition, sensitivity, TMJ disorders, periodontal disease, heavy oral biofilm accumulation. These are all oral manifestations that are common to see. Not all of them in once, but just here and there. Modifications of dental, so instruct at the patient's mental age. So that's good thing to highlight. Not so much their chronological age, and this is the same thing with an 85-year-old patient who has some kind of cognitive dysfunction. You want to educate them where they're at like their mental age, not their chronological. May need extra time with OHI explanation. Utilize the caregiver, build trust, repetition, collect data about daily function and skill set to kind of try and figure out your patient. Spend that first appointment really trying to figure out their routine and what they have available to them and how likely they are to be able to handle the information that you're giving them. Sequence after plan is made, begin instruction with familiar activities. So you kind of want, if it's somebody that has you have a patient with autism that has a lot of anxiety about the noises and the devices, sequence it so that it's always the same. They might always need to see you. They might never want to see anybody else. And you always do kind of a same routine. So when they come in, they all excited because they know first we do this and then we do that. You know, they're used to it, and it helps the whole process along. I'm never gonna get done. Okay, so Down syndrome. Here are some things to know. Read through here. This is just some etiology. You don't have to worry so much about that. I would, be familiar with the fact that it's trisomy 21, and it's majority of cases is trisomy 21. And then I like this image. Where's the image? Oh, there it is. Oh my gosh, I'm like, where'd it go? I like this because this shows how what should happen is the division of these chromosomes, and what ends up happening is this down here. So you don't have this, they don't go where they're supposed to go. So that just kind of gives a good visual. So that's, if there was a test question on it, it would probably be about this. Medical considerations for individuals with Down syndrome. These are all the things that they might be susceptible to. So these are things not necessarily, but like congenital heart disease in 40% of patients. So when you have a patient in your chair that has Down syndrome, the first thing that you just want to think about is, oh, do they need pre-med? Let me check and see. So just go through this and be familiar with some of the things that are more common. It is common for them to have neuropathological changes similar to Alzheimer's. Sleep apnea is very common, and that usually has a lot to do with the actual physical shape of their oral cavity and tongue and the structure of their jaws and everything. So read through that. This goes into a little bit more detail. A lot of times patients with Down syndrome can have large tongues, they can have small mandibles, they can have small teeth. And so malocclusion or missing teeth, congenitally missing teeth. Periodontal disease is a higher rate, but it's not necessarily because they don't brush and floss. It can be immunodeficiency. So that's kind of interesting. Yes, it can be because they just don't perform very good oral hygiene, but it's also something that is kind of attributed to the Down syndrome. And then the tooth loss can be attributed, this last one, it should probably be clarified. So it can be because of the periodontal disease, but what's causing the periodontal disease? Does that make sense? So it can be more than just calculus and plaque. So this kind of is a little bit repetitive. It's showing some pictures, some things. If there's sleep apnea, or there's like if the tongue protrudes, or the mouth stays open a lot, then we're going to have more things like fissured tongue, candidiasis, dry mouth, heavy salivary flow. So they can either have like a dry mouth issue, or they can have heavier saliva and more of a drooling situation. So it can go either way. Yeah. Macroglossia, so large tongue. So sometimes their tongue, yeah, so their mouth is small. Their mouth is small, and then the tongue, and sometimes their tongue might not even necessarily be that big, but their mouth is small. So, and then sometimes they can have macroglossia, like a larger tongue and a smaller mouth, which makes it even worse because they just don't have room. And that's going to cause, sleep apnea. And then, yeah, no, that's fine. So this is just, again, just going over some of these conditions. There's some things that you'll see that are kind of common with the structure of their mouth, the high vaulted palate, the shape of the hands. Here's images that show a lot of this macroglossia. And so the tongue just protrudes. And I'm trying to think of what's going on with the eye. I don't remember what this is. Was that on the other slide? It could be. There's something about the eyes, but I just won't. I'll make sure it's not on the test. I don't know why I put that in there, but I did know at one time. There was something about the eyes, but anyways, it wasn't dentally related. So modifications to treatment. So patients usually are very good patients. I have never had a patient with Down syndrome that actually wasn't a great patient, but I'm sure they exist. They could be, unhappy and not want to be there and not sit there well and be scared, so I'm sure that but generally speaking, they're very content and affectionate. Assess their intellectual level, because do not assume that they might have absolutely every idea about what you're talking about, and be very able to educate and show what you need to show. So you kind of have to feel it out. Slow, explain the care, simple terminology, calm demeanor. Consider the pre-op medications if you need to. Shorter appointments, that's going to be kind of a repetitive thing. Short morning appointments. Everybody needs a short morning appointment. That's for almost every condition on the planet. Caregivers. So now we have the autism. We really have to stop here. So I'm just going to make sure you read through these different types of autism. The classic autism is the most common. These are childhood disintegrative disorder and pervasive developmental disorder. So just be familiar with these different types of autism: autistic, Asperger's, Rett's. Just be familiar with all those 5 different types of autism. Yeah.
They don't separate them out.
That's my alarm. Like this is, oh, maybe I have to update my thing.
Yeah, now autism is like all on a spectrum, and Asperger's is like on the spectrum. Not condition.
Yeah.
It's not its own diagnosis of Asperger's, it's just autism on a minor high function.
Wow.
Like Asperger's falls in those levels.
Yeah.
But you don't-
I was gonna say, I think I need to update my
It
autism
changed,
slide.
like, with them last year.
Interesting.
APA therapist, I could ask if she has any information on like a pamphlet form on what we can.
That would be good. Do that, because I think I definitely need that updated then. So what we're going to do with the autism is you're not going to be tested on anything that has anything to do with autism for the quiz. So just don't worry about autism. So mark that, because obviously I have to update that section. So we'll do that. Yes. Amber.
Yeah, Dr.
Yes, I think I could too. Well, that's it. Okay, so that's the end. This autism is the last bit, and I'm just gonna say hold off. You can peruse it, but because some of the stuff still applies for the oral hygiene type stuff. So just peruse the stuff, but I'll take out any questions that have anything to do with autism. So we won't test on autism. All right, you guys are done. Thank you. Yeah.
Reaching out to my friend and I'll let you know.
Yes, that would be very helpful. Thank you. Angela, I hope you heard me the whole time. You can log off. She might have. She did. I'm talking to nobody. She's all like, see ya. Gonna stop the recording.